on primary immunodeficiency disorders. The symposium is hosted by the Kenyatta National Hospital and the University of Nairobi. I'm Valerie Magutu, a clinical pathologist with the Department of Human Pathology at the University of Nairobi, and I have the pleasure of being your moderator for today's session. Thank you so much, everyone, for joining us. So today, on our final symposium day, as with previous symposium days, we have a lineup of very exciting and informative sessions that are in line with the theme of toward better primary immunodeficiency disorder awareness, early diagnosis, and optimal care. So starting us off is our first speaker, who we're very honored to have with us, Dr. Nizar Maloui. He's a pediatrician specializing in immunohematology at, and I'm sure I'm going to bungle this, please forgive me, doctor, Neckar Enfants Malades University Hospital in Paris, France. He manages the French National Reference Center for Primary Immune Deficiencies. He also serves as chair of the International Patient Organization for Primary Immunodeficiencies Medical Advisory Panel. He's the founder and coordinator of the innovative transition from pediatric to adult care program for adolescents and young adults with rare and chronic diseases. Today, Dr. Nizar is going to talk to us about common variable immunodeficiency. Welcome, Dr. Nizar.
Thank you very much for this kind introduction. Thank you to all the organizers for giving me this opportunity to be amongst invaluable colleagues. And I wish we could have done that in face-to-face meetings in Nairobi, obviously, but I'm sure it will be for another time. So I have been asked to talk about common variable immunodeficiency. So I will start by sharing my slide, my screen, and I believe, yeah, here it is. Can you see it?
Yes, we can, doctor.
Right, fantastic. Okay, thanks again for giving me the floor. So this is,
I'm so sorry. Yep. Sorry to interrupt you, Dr. Nizar. Your slides seem to have disappeared.
Okay, sorry about that. I'll try again. I think you can see them now.
Yes, we can.
Right, great. Primary immunodeficiencies, obviously you're all very much aware about this introduction. But anyway, I thought I could just give you an overview of, on this little cartoon that primary immunodeficiencies are complex diseases, and patients with PID can experience different kinds of comorbidities, such as obviously infections, but also immune dysregulation complications such as autoimmunity, autoinflammation or inflammation, granulomas, allergies, and also benign or malignant complications. And obviously the diagnostic delay is usually considered as too long. And there I thought I could share with you this very interesting tool to help shortening this diagnostic delay, which has been developed by our Welsh colleague Stephen Jollis and collaborators, and that he named the calculated globulins. And you can learn about that on his publications, and also on the recent IPOP webinar, half an hour. You can learn much more about this very simple tool to screen for immune deficiency. So PIDs are rare, but multiple, more than 500 and 50 genes have been discovered so far, and 20 to 30 new genes are published every year. So it's kind of difficult to keep up with all the knowledge. There are complex diseases, but there are chronic, lifelong diseases, and obviously the therapy will need to be adjusted throughout through the life course of these patients. The prognosis is often severe when misdiagnosed or diagnosed at a very late stage, or if the patients are not adequately treated. So there's definitely a burden of the disease. The burden of treatments also appears to be more and more identified and studied. And there is a need for a specific high-level management and care with immunoglobulin replacement therapy, but also transplantation, bone marrow transplantation, sometimes solid organ transplantation. So there's a need for an increased awareness to improve the diagnostic rate, and in order to ultimately improve the survival. And also, I want to stress that I think it is very important to consider the patient's needs at different stage of their life. Obviously, children, teenagers, and adults and elderly have different needs. So that's just for a short introduction. What about the epidemiology? So this is what you can find if you go on the EASD, being the European Society for Immunodeficiency website. There's a registry section in which you can find a reporting tool that I developed when I was the chair of this registry. And so far, there are almost 30,000 verified patients. And as you can see here on the blue part of the pie chart, 50% of these patients have a predominantly antibody disorders. So within this group, the majority have what is called a hypogammaglobulinemia, in contrast with agamaglobulinemia, mainly Bruton disease, and also class switch combination defects / hyper IgM syndromes. So within this green group of hypogamma, then you can find the common variable immunodeficiency, or CVID, which account for almost 2/3 of this hypogamma, but account for 44% of the predominantly antibody deficiencies and 20% of all PIDs. So this is in line with previous reports and overall around the globe. This is what you can find about epidemiology and frequency. So I want to stress the fact that hypogammaglobulinemia is quite frequent, and most of the time that would be a secondary hypogammaglobulinemia, another primary immunodeficiency. So lots of these secondary causes of hypogamma are listed here. Main causes are listed here. Medications, obviously mostly due to immunosuppressants, but also other drugs for seizures, or in neurology or in rheumatology can lead to hypogamma. Also, protein loss through the gut or kidneys have to be screened for. And malignancies, and mostly B-cell malignancies, B-cell lymphomas or multiple myelomas, but also cryoglobulinemias can lead to that. And if there are enough arguments for a primary immunodeficiency, then you have to look for XLA or other form, or autosomal recessive gamma, XLP for X-linked lymphoproliferative disease, hyper IgM syndrome, but also many other PIDs can lead to hypogamma ultimately, and many combined immune deficiencies, so T-cell defect mainly, but the phenotype might look like a common variable immune deficiency. So again, in terms of frequency, what we know is that the CVID is as frequent as 1 out of 10 to 50,000 individuals These data are derived from Caucasian/white population cohorts, and it is widely accepted that in people with African ancestry, CVID is less represented, but we don't know how frequent we could expect CVID to happen. Are you still, can you still listen to me? Is it still okay? Just to make sure that,
Yes, sir.
yeah, right. Okay.
Yes, we can hear you. Thank you.
Fantastic. So if you, so this slide, which is very busy, so just don't worry about, don't look into details into that. What you need to understand is that there are now high-level diagnostic criteria for all primary immune deficiencies. This is the work that I co-led with colleagues from the EASID registry, and you can find the publication here, recently published in 2019. But this document is a PDF document that is free to, for you to download on the EASID website, the registry section, and there's a tab labeled Diagnostic Criteria. And now this document is a 200 pages document, so lots of work, which is collaborative and international. And as you can see here, these are the criteria you want to meet or not meet for your patients in order to be labeled correctly as a common variable immunodeficiency. As you can see, you need to have at least one of the following: an increased susceptibility to infection, or one or more autoimmune complications, or one or more granulomatous disease, and so on and so on. And obviously, the landmark of the CVID diagnosis in terms of biology is to have a marked decrease of IgG, and or the same for IgA or IgM. So this is very important for you to have. So you don't want to label a patient with a CVID only based on a protein plasma electrophoresis. You need to have the IgG, IgM plasma level. And of course, if you can do the antibody responses to immunizations or documented infections, that would be great. Exclusion of secondary causes of hypogamma. And very importantly for pediatricians in the room is that you don't want to label a young kid with CVID, and we set up the threshold at 4 years old. So below 4 years old, you should rule out other forms of primary immune deficiencies, and mostly combined immune deficiencies, which are T-cell defects and have a usually poor course and prognosis. So to help for this, we define thresholds in terms of CD4 T cells and naive CD4 T cells. And in case all of these, your patient doesn't meet all the criteria here, there are alternative diagnoses on the right column. So this is quite a busy slide, but just for you to understand that CVID can mimic another form or multiple forms of other primary immune deficiencies, and with a different prognosis and different genetic background, and potentially a specific management, including bone marrow transplantation. So again, this document is free for anybody to download. So please download it, share it. And obviously, I'm totally aware of the fact that not everything can be done in all countries, and I'm very much aware of what can not be done or be done in different countries of Africa. But I believe that in Kenya you have lots of available tools to do the workup. Right, so regarding the workup, actually, so clinical history of personal history and family history is very important. So obviously, a history of autoimmune disease or inflammatory disease, and obviously severe infections are very important to look for. Please ask if there is consanguinity. Sometimes it's not very easy it's not so clear, so do draw a very specific pedigree. Look for chronic medications to rule out a secondary immunodeficiency. Do blood and urine tests to rule out for plasmacytoid malignancy. So the hemogram and the CDC, obviously the lymphocyte immunophenotyping as highlighted before, IgG, IgM, and also a chest X-ray and or CT scan. For two reasons. First, you can rule out rare causes of hypogamma in adults called the Good syndrome, derived from Bob Good, an adult clinical immunologist from the US. And also, so there would be an enlarged thymus. So that would be the key feature. And also to have a standard description of the lung damage, because then you will have to just to look for the appearance of other, like bronchiectasis, for example. So again, coming back to the fact that CVID is really what you want to retain as a diagnosis at the end, after having performed an extensive workup in order to exclude other forms of gammaglobulinemia or hypogammaglobulinemia and combined immune deficiency or immune dysregulation diseases with hypogamma, like the XLP, as I mentioned before. So what about the genetic disorders in CVID? Well, actually, CVID is considered to be most likely a polygenic disease. But there are 20% of patients who in whom we can find a monogenic disorder. And recently, these three genes, so in the last 5 to 7 years, have taken the lead in terms of the trio of most frequent genetic disorders found in patients with CVID. And actually, PI3 kinase deficiency and APDS1 or APDS2 are considered to be a combined immune deficiency. CTLA4 deficiencies or LLBI are also considered to be rather a combined immune deficiency, but obviously there is a full spectrum. And as you can see on the right, there are other genes that are less frequent. And as of today, there are 25 to 30 different genes. So yeah, so you can report to you can look at this publication that was recently published in Blood, and it's a very nice overview of the cohort in the US, in Sweden, and in Iran. So I believe it's very interesting. Right, so now what about management? So we published in Clinical Infectious Disease in 2014 a recommendation on all PIDs, specifically about CVID, but other forms of PIDs are also highlighted after a careful and thorough review of the literature at the time, and a Delphi method in order to bring all experts around the table and different rounds of discussions leading to this final consensus. And as you can see here, there are 3 different dimensions. So the chemoprophylaxis, the immunotherapy, and also the vaccines. So the chemoprophylaxis can be indicated depending on the clinical status of the patient. So whether or not the patient has bronchiectasis already, so that or not. So in case of no bronchiectasis, we would go for a cotrimoxazole or Septrin, and otherwise with azithromycin. And sometimes also inhalated antibiotics can be of help. No fungal prophylaxis or viral prophylaxis is needed. I have to mention here that I highlighted in red here, the LOCID. LOCID is late onset combined immune deficiency. So it's mostly these forms of CVID with very low T cell. And we tend to consider that they have a different course with opportunistic infections, more to immune diseases, and then they need a specific management. So they might need a viral prophylaxis or a fungal prophylaxis. So what about immunoglobulin? And we designed, we agreed on a threshold on 3.5 grams per liter and or one severe infection or 3 or more moderate infections per year. So as you can see, it's a combination of a clinical criteria and a biological criteria, and we believe that these patients should be carefully managed with these approaches. Obviously, they might need some immunizations, pneumococcus, Haemophilus, meningococcus as well, seasonal flu vaccine. So what about the live vaccines? Again, it depends on the, how the T cell count is, how low the T cells might be, and in that case, you don't want to give them live vaccines, and also for the yellow fever, depending on the IgG plasma level. Right, so I'm sure you're all aware about what is available as of now in terms of immunoglobulin replacement therapy. So it's a long-term therapy. Not all patients with CVID or primary immune deficiency might require immediately to be put under immunoglobulin replacement therapy. Remember the clinical criteria as well. And then what choice? Well, patients might have the choice between intravenous, subcutaneous, or facilitated subcutaneous immunoglobulin, depending on the level of education, the availability of the product in your center or your country, how high you want to have a IgG trough level in the plasma, how frequent the patient might want to be infused either at home or at the hospital, and also depending on some potential adverse events, even though the current products are usually much better tolerated than the products that were available 20 years ago. So coming back into more details into what the patients with CVID might undergo or experience during their lifetime. So again, a large series of patients from the European Society for Immunodeficiency Registry showed that as high as 1/3 of the patients experienced at least one pneumonia, one autoimmune complication, and splenomegaly is very frequent, which is part of the lymphoproliferative syndrome. Bronchiectasis is as high as 23%, and less frequent, but sometimes very difficult to treat, the granuloma of the skin, but also of inner viscera or inner organs like the spleen or the liver or the lung. The enteropathy can be very nasty and difficult to treat. Some patients undergo splenectomy, not only because the spleen is enlarged, but also to diagnose or to look for a lymphoma. And as you can see, there are malignancy, there are solid tumors or lymphoma, and they are very frequent in CVID. And actually, CVID is the most frequent PID leading to malignancy, except for DNA repair disorders such as ataxia telangiectasia, obviously. And again, allergies, so in the French PID registry, these are 21% of the patients with CVID had at least one significant allergy. And not all of these complications appear at the same time. So as you can see, obviously there is a wide distribution, as the box plots show. But so these are organized or by decreasing order of age. Younger age for bronchiectasis and autoimmune cytopenia, and then enteropathy, and CVID diagnosis can happen after these complications, and then benign lymphoid hyperplasia and lymphoma can happen 20 years after that, and in between, patients can experience granuloma or liver disease. So about liver disease, this is probably an overlooked complication called hepatic nodular regenerative hyperplasia. So it's mostly an intrahepatic vasculopathy leading to hepatocytic lesions, leading to then regenerations, leading to a formation of nodules, regenerative nodules, that lead to a compression, a physical compression of liver tissues and veins, central veins and portal veins, then leading to portal hypertension, and then lead to complications, including bleedings, gut bleedings. So it is a very difficult complication to treat, I have to say. Sorry for this busy slide, but this is a quite recent publication on the pulmonary disease burden in PID disorders derived from the US PID registry. And as you can see on the right part of the slide, they discriminated the lung diseases by 5 different components, so the airway, the parenchymal lesions, the vascular lesions, or the pleural lesions. So in CVID patients, more than half of them have an airway disease, but a significant portion of them have also a parenchymal disease, so I'll come to that a little bit later. And I thought it would be interesting for you to have a look at this left part of the slide, because if you look at the airway diseases here, it's not only CVID, although CVID is most dominant. You can find them also in combined immune deficiency or gamma or phagocyte effects. So it's really scattered throughout all PID categories. So yeah, GLILD, G-L-I-L-D, stands for granulomatous and lymphocytic interstitial lung disease. It's a very nasty disease. It's more and more studied, and we have now more insights on the natural cause of the disease, but also, and most importantly, on how we can help patients with the available drugs. And this paper that came out very recently at the end of August this year is probably the most important series so far. It's a US group working on this field since many years. And they compared a cohort of CVID with GLILD and CVID without GLILD, 39 patients in both groups. In the group of CVID with GLILD, there were mostly 4 genes involved in gene defects involved in this cohort. And they treated these patients with either rituximab or Rituxan, so it's a monoclonal antibody that kills mostly the B cells because they harbor the CD20 antigen at the surface. And with azathioprine, so Imuron, or MMF, which stands for Cellcept, or mycophenolate mofetil. And most of the patients had a good course, as you can see here on the left panel with the CT scan. So the score is there, so they derived a score, and 16 is not the highest, but amongst the highest, the high tier of the scores. And as you can see, there are airway and parenchymal lesions of both lungs, and the same patients after these treatments had a significant improvement. But not all patients, of course, can have such a positive outcome, and some patients relapsed, and some patients unfortunately died. And then you can go for another course of the same regimen or change the regimen. But overall, it's a pretty positive outcome thanks to these to the series, retrospective case series. And I believe this, I'm coming to the end of my talk, and I wanted to leave you with this important message regarding neoplasia, so malignancies, and so all PIDs can lead to an increased risk of malignancies. Most of the malignancies would be lymphoid malignancies, so hematological malignancies, B-cell lymphoma, and mostly DL, BCL, so diffuse large B-cell lymphomas. And in our French registry, amongst the almost 8,000 patients, we had 5.5% of the lymphoid malignancies, of B-cell DCVID patients having a lymphoid malignancy. And as you can see here on the box plot, the age of onset of these malignancies can differ between the groups of PIDs here, and differ between the type of malignancy. So for the Hodgkin lymphoma or the other lymphoid lymphoma, DLBCL, the age of malignancy is pretty young, around 30 years old. And for non-Hodgkin lymphoma or plasmacytoid cell disorders, the age is much higher, as far as 50%. So that would be for the CVID. But obviously for other kind of diseases, and especially the T-cell defects and the immune dysregulation defects, the age and the type of malignancy, the age would be younger and the type would be different. And so what about for your CVID patients over time? What we derived from our data is that the risk of malignancy increases over time, starting age 15 to 20 years old, and increases steadily up to 80 years old to reach 11% of probability of occurrence of a lymphoid malignancy. So overall, the survival in CVID patients is poor compared to the general population. So that's derived from a publication from the US group, the New York group, from Charlotte Cunningham-Randalls. And so between males or females, there's a difference compared to the general populations. And obviously, a CVID patient without complication is most likely to have a better survival after CVID diagnosis, so 40 years after, 95%, whereas 42% in patients with one or more complications. So what would be the complications leading to a death? And any complication would have a hazard ratio of almost 11, statistically significant here. But in more details, these factors would be having a gastrointestinal disease, having a liver disease, a lymphoma, a chronic lung disease, or malabsorption. Right, so this is my last slide, and thank you for your attention, and I'm happy to take any questions, and I wanted to thank NBI for their support in organizing this meeting and my talk. Thank you.
Thank you so much, Dr. Nazar, for that very informative talk on common variable immunodeficiencies. We do have actually one or two questions. One is on race. Is there a racial risk for CVID, or is it that data from Africa or sub-Saharan Africa is underrepresented?
Yes, so that's probably there's probably a difference in the frequency of CVID in Caucasians rather compared to non-Caucasian, so derived from studies in the US, for example. They show that people with African ancestry are less likely to have a CVID. But I believe that when data from Africa and especially sub-Saharan countries will be available, that will give a much better insight.
Okay, thank you so much for that. Also, maybe you could tell us, personally, I was wondering, you know, maybe the two major challenges you had when you were setting up your registry, because that's something that we are into here for a number of disorders. And I know Dr. Barras is interested in setting it up with the A team for PIDs. What are two pitfalls you would advise her to avoid or tell her to prepare for?
Well, there are many pitfalls. So, you know, it's a very, very important question. I think you can set up a registry with you know, many different aims, different goals. So you should probably define your goal in order to what do you want to, where would you want to be in 10 years from now? Because it takes time. It takes a lot of time. And I guess that the second pitfall would be to ensure the sustainability. So because you need people to contribute, and they need to, I mean, it's a long-term process. So sustainability is a key issue. Because you said only two, right? So
yes, I did.
Thank you. I'm sticking to the question.
Thank you so much. I see Dr. Nala has also commented on the data from Africa, and she's echoed your sentiments that there's not enough data. I think that'll, you know, bring us to the end. I would also like to thank you for pointing out the cutoff age for diagnosis at 4 years. Just on behalf of, you know, Dr. Barras and the immunology department. We get a lot of requests below that. So thank you so much for pointing that out. Thank you for the talk. We really enjoyed it and hope, you know, we'll be able to invite you to give another one soon. Thank you so much, Doc.
Thank you so much for having me, and it was a pleasure. Thank you.
Thank you. Great. So we're heading into the next session in which we'll discuss multidisciplinary approach to care for the PIDs. And we have a really equally eminent panel to answer your questions. So the first person I'll introduce is Dr. Diana Marango, a consultant pediatrician and pulmonologist. Dr. Diana has an MPH in global health from UW, an MPhil in pediatric pulmonology from UCT, and a PhD in tropical and infectious diseases from UON. She's a lecturer in the Department of Pediatrics and Child Health at the University of Nairobi. Dr. Diana, please say hello if you're with us.
Good evening, everybody. I hope you can hear me.
Yes, we can.
I'm trying to just share a few slides. Can you see?
Yes, if you'll just give me a minute to say hello to the other panelists. But
oh, sorry.
See the slides. All right, thank you so much. Next up is Dr. Lawrence Owino, who's also from the Department of Pediatrics. He's a lecturer, a colleague of Dr. Diana's, also a fellow in public health and research, and the national chairman of the Kenya Pediatrics Association. His aim or aspiration is to be a leader in research in childhood diseases with a special focus on musculoskeletal and other non-communicable diseases. Dr. Owino, say hi.
Good evening. Hello.
Hi, Lawrence. Thank you so much for joining us.
Thank you.
All right. Dr. Anne-Marie, you're up next. She's a pediatric ID specialist at KNH. Her interests include pediatric and adolescent HIV, primary immunodeficiency, tropical and travel medicine. She's a member of the Kenya Pediatric Association, the Infectious Disease Society of Kenya, and the European Society for Pediatric Infectious Diseases. Anne-Marie?
Hi, good afternoon, everybody. Good evening, sorry.
Good afternoon and good morning for those in different time zones. Thanks so much, Doc. All right, and last but definitely not least is Dr. Eugene Ganga, a lecturer in the Department of Clinical Medicine and Therapeutics, School of Medicine, University of Nairobi. He also has a fellowship in rheumatology and has served as the Vice Secretary of Arthritis Society of Kenya. He has a keen interest in rheumatology, in particularly in particular the pulmonology aspect. Dr. Eugene, please say hello.
Hi, thanks for having me.
Thank you so much for joining us. All right, so let's launch right in. Dr. Diana, before we go into your, I think you had some slides, we did have a few questions for the panel. Would you like, I'd prefer to go into those first before your presentation, or would you like to present first?
I'm open to either. It was just I had just like 5 slides that I wanted to mention.
To share.
To the end, yeah, that's fine.
Okay, fine. All right, so just a few questions, and then actually when I go to your question, maybe you could share with us the slides. So this year, Kenya signed a standard declaration and committed to the provision of primary health care for all, reiterating their commitment to the Alma Ata Declaration. So we all know that key to achieving universal health coverage is quality primary health care. So in your opinion, in less than a minute, and based on your experience, expertise, and practice, which element, if strengthened, would result in improved management and outcomes for patients with PID nationally, and why? Maybe I can start with you, Dr. Eugene. What element of primary healthcare would improve management for patients with PID?
I think the thing that would help the most would be documentation, because I think we don't have enough data. So I think coming up with this registry will go a long way. Because I remember like the time when I was training, whenever my professor would mention those diseases, I'd say, so those things you'll never see in Kenya or Africa. So I think documentation will go a long way. Also, I think provision of at least the food to curb malnutrition, because malnutrition has an impact on the immunodeficiency. Improving immunization also go a long way. Yeah.
Okay. Thank you so much, Dr. Eugene. Dr. Lawrence?
Thank you. In addition to what Eugene said, I think we must not shy away from advocating for access to the treatments that work. We know that we would require, for example, immunoglobulins for replacement therapy. We would also need to improve access to hematopoietic stem cell transplant. And we also need to improve the diagnostics. And now some of these things, when we talk about primary health care in our settings, are actually excluded because people are trying to come up with some packages, which actually just had mainly the basic things like malaria care and pneumonia. These are the things that a good number of people may actually be able to afford, as much as they are responsible for most of the mortality. But if we diagnose somebody with these conditions we are talking about, we are highlighting today, then sometimes the treatments are not easily affordable or are not easily accessible to the individual, but could easily be brought in if we put it in the national priorities list. So I would think in summary that better or increased access to proven treatments that work would go a long way in improving care to these patients. Thank you.
Thank you so much, Dr. Lawrence. Dr. Diana?
Thank you very much. So for me, I think diagnostics, as Lawrence pointed out, but where I want to maybe touch on, especially from a pulmonologist perspective, is at the primary healthcare, we have simple things like chest radiography. It might not need to be that expensive as the CT, which might be found in tertiary facilities, that will give us clues of some of this, of primary immunodeficiency. We may see that ground glass opacification in this child who is maybe HIV negative. you're querying, is this PCP, is this a CMV? So having that at the back of your mind, so chest radiography. And then of course the other side, and you saw in the previous presenter, he showed images of bronchiectasis, and there are early signs that we can pick on chest radiography. Secondly, I'll talk about, in terms of still diagnostics, I would like to talk about induced sputum, very simple strategy that can be used in primary healthcare to identify those unusual organisms. Again, I'm talking about this, still your PCP, you'll see your Serratia or different organisms. So you have to strengthen diagnostics also at the microbiological level for these odd infections. And finally, and I think maybe I'll just say that at primary healthcare, it'll be diagnostics, and maybe I'll choose the chest radiograph and induced sputum as simple strategies. Thank you.
Okay, thank you so much, Doc. As you've mentioned microbiology, that's a really good intro to our ID specialist. Dr. Anne-Marie, what are your thoughts?
Thank you, Valerie. I think for me, like Dr. Eugene has mentioned, because we're talking about really the most basic dispensary, I'll take it back to getting a good history, doing a good physical examination and monitoring the children. Two primary functions that happen at our primary care level are growth monitoring and nutrition. Malnutrition, like has been mentioned severally, remains the most important cause of immune deficiency in our children. It's a thing that we are all taught to do, can be done by nurses, but often you find either the information is not taken, the child is not examined, or even if it's there, then we don't use it to make clinical decisions. So to emphasize the tools that we have, the Well-BB booklet, those weighing scales, the MWAC measures, and so on. Thank you.
Okay, great. Thank you so much for that insight, panelists. Okay, I'm going to segue into questions directed to Dr. Diana first. So Dr. Diana, what respiratory findings or clinical presentations that are specific to the respiratory system could be used as warning signs of a PID by, general practitioners or pediatricians? What would you like healthcare workers to keep in mind or be aware of, since they might not have access to your level of care?
Thank you, Valerie. And this is a very important question. And I would try to remind us the mnemonic SPUR, which is SPUR, especially for infections, serious infections, okay? Persistent infections, unusual infections, recurrent infections. So for me, from a pulmonology perspective, these are some of the keys, very simple things that maybe someone should remember. And going back, I think I'm just reiterating, just going back to your chest radiography, yes, you're seeing a lot of pneumonia, but what are those things that will be clues to this is just more than just a pneumonia, okay? Of course, as Dr. Anne Macharia explained, the history and the physical exam, and everybody in the last 3 days has been talking about this. But at that, for the general physician, I think I want them to remember SPUR, and especially those unusual bugs you're not expecting. You're seeing your Pseudomonas, you're seeing your Serratia. This is abnormal. Think a little bit more. This could be a primary immunodeficiency. Thank you.
Fantastic. Thank you so much, Doc. That actually, since you've gone back into the infections, it's like you're introducing our next question. Dr. Anne-Marie, this is for you. What pattern of infections or perhaps organisms could serve as a flag or warning sign of an underlying PID? I think Dr. Diana has mentioned your pseudo and your Serratia. Is there anything else that, should be a red flag or a warning sign if a general practitioner or nurse gets back her labs or a healthcare worker and sees this bug? Should they start thinking there's something going on with this patient's immune system?
The acronym that Diana has mentioned, meaning that an infection that's more severe than usual, persistent, unusual, or recurrent, I think is the key thing. If we do get time, I think both of us did have some cases, very brief ones, that may highlight what we're discussing now. Thank you.
All right. Okay, I will definitely give you some time at the end of the session. Dr. Lawrence, this is for you. when should general practitioners or primary level healthcare workers, or even pediatricians, refer a patient with suspected PID to you, or refer a patient to you for workup, without provisional diagnosis?
Yeah, thank you for that. I think from the previous speaker, and unfortunately I was not able to join the other presentations, but it should have come out quite clearly that autoimmune diseases are part and parcel of the manifestations of PID or primary immunodeficiencies. And a good number of these children may actually manifest with systemic lupus like symptoms. So what is it that you'd see as a primary health care worker, or even as a general pediatricians? This is just the same typical features that you'd see in other lupus. So that would be skin manifestations, for example. Patients manifesting with the discoid or round lesions or sort of plaques that would be a manifestation of possible lupus. And this is in the background of everything else that we have said. For example, there is infections, there is the issue of failure to thrive or weight gain. And then you find that the patient has discoid lesions, which could be a manifestation of discoid lupus. Sometimes they just manifest with the features of eczema, for example, or eczema-like skin lesions that are not responding well to the routine or normal care for eczema. So those might actually also be an indication of lupus. We have alopecia. Some of these children may have patchy areas on their head where there's no hair, or patchy alopecia, which might be a manifestation also of discoid lupus. Or they may have diffuse alopecia, just a sparsely distributed hair, which might be different from maybe what we see, for example, with just severe malnutrition. Other than that, they may manifest with the wounds in the mouth. They may manifest with arthritis, basically swelling, or they manifest with renal disease. Okay, and for example, we have, sorry, I think my internet is unstable. I hope you're getting me.
Yes, we did. I think where we did leave off was you talking about the skin manifestations, renal disease.
Yes. Yeah. So I was just on renal disease, which is usually quite simple when we are talking about rheumatology. All you need is a urine dipstick, and when you find proteinuria or hematuria that cannot be explained by some other obvious cause, then you also suspect lupus and investigate appropriately. So basically, in summary, suspicion of lupus is based on the skin manifestations, unexplained renal disease, and arthritis. And once you see patients manifesting any of those, then you may suspect further workup. Lastly, we have some...
I'm going to have to cut you off because I do need to give Dr. Eugene. I'm so sorry. Obviously,
That's fine.
From you. And would really recommend that Dr. Barasa sets up a session where we can have more time with you and the other panelists, because we have so much to learn. So sorry about that. So Dr. Eugene, similar question to you. What advice would you give healthcare workers dealing with adult patients? For example, GPs, even OBGYNs, on warning signs of a primary immunodeficiency in adults. When should they, stop looking for horses and, think that this is a zebra? Yeah.
So I think is who to screen, in short. That's what you're asking. So basically, a patient who has had recurrent infection, and usually the question would be, how would you define a recurrent infection? Some of the definitions that are available, like a pneumonia, that's maybe more than twice in a year, has been confirmed by a chest X-ray. Other things are like deep-seated abscesses, or somebody who has required antibiotics for a prolonged duration of time, or unusual bugs, like how Anne-Marie has said. those are some of the things that should maybe make you think about something like PID. Other things in the background of that would be autoimmune disease, things like the lupus, the rheumatoid, eczema is also there, lymphoproliferative disorders. Sometimes they get a bit of lymphadenopathy, they get splenomegaly, and also last a family history of the disease. So when you have that, you start suspecting. So like what Anne-Maria said about the history taking is very important. And then when you do the lab works, just a simple hemogram should be able to tell you what is going on. Because if we can see these unexplained neutropenias, unexplained monocytopenias, if you go to the really big tests looking for the immunoglobulins and the rest, at least that should probably guide you that possibly there could be something else going on. And probably pull out the other differentials. And differentials, there will be probably drugs, protein-losing enteropathies, things like nephrotic syndrome, the malnutrition and the rest, and the eczema. So if you have that in the background, at least it should be able to guide you to say that this is possibly a PID.
Thank you so much for that really succinct answer, Dr. Eugene. So we do have a few comments regarding the last presentation and also this one, but I thought that maybe we could give Dr. Anne-Marie and Dr. Diana a chance to maybe put up their case presentation. I don't know if this was aimed at the panelists. I would like to give you about 3 minutes. I'm so sorry, I'm being a bit mean with time, but it wasn't something that was factored in, but I also don't want all your hard work to go to waste. So Dr. Diana, do you think you'll be able to maybe point out the salient features in 3 or so minutes?
Yes, I can. So
excellent. Thank you. Please proceed.
So some of this I think I had already touched on. Sorry, the slides are not moving. And I wanted just to highlight that when we are called in as respiratory physicians, my most recent case is just last month, a term HIV unexposed neonate who is phenotypically a trisomy 21 presenting with neonatal sepsis in respiratory distress. And the issue here was they were not able to wean off the oxygen. They had been reviewed by a cardiologist who had seen identified a VSD and pulmonary hypertension, but the cardiologist is the one who actually thought to call me in. And of course, we worked them up, ruling out other comorbidities that are common in Downs, like aspiration and reflux. And we considered the PID, and I'll just show you images of why that was a possibility based on their chest radiography. And this turned out to be a combined B and T cell deficiency. The karyotype confirmed the trisomy 21, and a FISH for the Q22 deletion was negative. The next patient was a patient during my fellowship, I managed to review. A 19-month, came into our service when they were 19 months, HIV negative, failing to thrive, recurrent lower respiratory tract infections, coughing. But this child was different in that they were clubbed and hypoxic, which is very classical for interstitial lung diseases. And their workup did come up to be hyper IgM. And the third case, because I'm going to show you just briefly what all the imaging looks like, was a child who had, we confirmed to have hyper IgE. She had eczema from birth, recurrent wheezing from the age of 7 months, and recurrent infections. Eugene has talked about the deep fungal abscesses. She had this, she had herpes, warts, molluscum, and she had been hospitalized severally for severe lower airway obstruction. So treated as a severely uncontrolled asthma. Even went to up to having omalizumab, which is an anti-IgE monoclonal antibody. I'll show you also the imaging. Her IgEs were as high as 45,000. She had negative genetics for STAT3 and the DOC8 and type that had been talked about. And this is a child who we co-managed with rheumatologists because on lung biopsy, we did see some IgG4 deposits and there was a trial of rituximab. So I'm just going to highlight just why I thought chest radiography is really important. This is that first neonate I'm talking about. I want to just highlight this diffuse ground glass opacification. Can be so many things. Very prototypical for what we call children's interstitial lung disease. But when you see this, think PCP, and this is especially in a HIV negative patient, consider a PID. The second patient, who I mentioned with the hyper IgM, came in also clubbed hypoxic, an interstitial picture on the chest radiograph. I can show you that. You're seeing the diffuse ground glass bilaterally, but on CT imaging, you actually see that also, apart from the ground glass, they do have features of bronchiectasis. So we are seeing that. The third patient, the hyper IgE syndrome I mentioned, hyperinflated lungs, asthma typically. Look at this chest radio, CT. There's airspace opacification, there's nodules in here. It's not very typical, and that what warranted her lung biopsy. I show this last chest radiograph because that's the real extreme. This is what bronchiectasis on chest radiography does look like. We see this a lot in HIV infections, but if this child is HIV negative, think bronchiectasis. I mentioned induced sputum, and I mentioned what I haven't talked about is bronchoalveolar lavage, because this is something as a pulmonologist we can offer you to actually get a much lower respiratory tract sample. And I think I want to finish by just putting a plug for our pediatric pulmonology clinic, which is on Thursdays from 2 p.m. And we have quite a number of criteria for referral, and some of them actually point to those patients who we must suspect for PID. Thank you for your attention. That's the end.
Thank you so much, Dr. Diana. And I can also see a little plug for a steakhouse. I'm not sure if you're reminding us it's dinner time locally, but thank you so much for that excellent presentation and for keeping to time. So I'm just going to wrap up. There are some really wonderful comments by Dr. Nala Erwa, who is, I believe, the president of the African Society for Immunodeficiencies. And she's also emphasized what a lot of our panelists have said, the importance of referring patients with SPIR, failure to thrive in food abundance, unusually distributed or extensive eczema, autoimmunity, and unexplained end organ damage. And that at the level of primary healthcare worker training is essential. I'm so happy that all of our panelists are actually at either a teaching facility or are staff at an academic institution. And so this is something that they can actually promote. She's mentioned making use of international lists of medicines and diagnostics. And I will also highlight that IVIG is available on the Kenya Essential Medicines list. It is listed as an essential medicine. I think now the push would be for us to ensure that it's provided. And that comes to the next point of Dr. Nala, which is advocacy. There is a question, I'm going to take it as the last question because I really don't want to keep the Prof. Ndwati waiting. And it is for, I think I'll just aim it at all panelists. Hello, I have a patient who was suspected to be having PID. She's been attended by 2 gynecologists whom I know, but she's still complaining of discharge, pain, and itching. Also, she's had walked into many pharmacies in Nairobi, and she was given a number of antibiotics. Kindly help. I'm not sure this fits entirely into the PID, but realm, but I will use it as a segue to ask our panelists if they have any closing thoughts, and directions for referral for the last question. Dr. Eugene, any parting shot? Can I give you 15 seconds? Short and sweet.
So I think getting a further history will help. One thing I've come to learn, a lot of patients, especially ladies who have this recurrent infections that are supposed to be bacterial, actually end up being fungal. So I think also ruling out maybe just maybe a hypergenital subdural, some candidiasis will also help. And then also doing a hemogram, like I said, looking for the silent markers, the monocytopenia, neutropenia, that can guide. And then I think also, since we have the A project around, I think also involving the team will also help this patient. Yeah.
Okay, so I'm going to take as our highlights appropriate referral and use of a hemogram. As someone in hematology, of course, I have to echo that. Thank you so much for your time, Dr. Eugene. Dr. Lawrence, anything you want to say as we...
Thank you very much. Just to comment on what was posted, I'm wondering whether the listener meant pelvic inflammatory disease.
Perhaps.
Primary immunodeficiency. Maybe we just need a clarification. However, if it is primary immunodeficiency, I think there's already a team that has shown interest in working with these patients. and the referral pathway should be quite open. For the time being, I think most of the speakers from Kenya are at least in KNH, and we have a team in Aga Khan. Those are centers that we can start off with. Personally, I would like to thank everyone for the opportunity that I've been given. But as a pediatrician, I would say that there is a lot we can do. For example, with the vaccinations, we know there are vaccines that these children who suffer from this disease should absolutely get. And then there are those that should be contraindicated at certain times so that we do not end up causing harm to them. So there is something that can be done.
Thank you so much, Dr. Lawrence. So your parting shot is about shots, the vaccine shots.
The shots, thank you.
For that, thank you so much for joining us. Dr. Anne-Marie, anything you want to say? 15 seconds?
I'm wondering if you'll be able to give me maybe 5 minutes. I've spoken with Prof. Ndwati and she's allowed me to hijack some of her time.
I'm not sure if I'll be stepping on anyone's toes. Will it be 5 minutes or 3 minutes? This will be your parting shot.
It's a short presentation and parting shot.
Okay, fine. So I'm going to even cut it further down to 2 minutes, very short and sweet. Please take it away, Dr. Anne-Marie.
Thank you. So I chose to do these case presentations after discussion with Professor Ndwati. Can you hear me?
Yes, we can.
Yes,
Thank you, Prof. Yes, because I think throughout the course of the 3 days, what has really stood out for me have been the case presentations, and I've had some amazing light bulb moments. So there are 2 very short cases that we managed together with a team at Kenyatta in the course of my fellowship, and I'll just go ahead to share them. So the first is a 1-year-old female who presented with multiple joint swellings and fever from the age of 2 months. The swelling was initially at her left elbow, followed by the left wrist, then right elbow, and eventually both knees. And these symptoms progressed over a 7-month period. All this had been preceded by a failure of her BCG scar to heal. That had been administered on day 2 of life, after which it ulcerated at 6 weeks, and at 2 months, the swelling started. The mom went to a local dispensary where the wound was cleaned, and she was given antibiotics, but the swelling persisted. She also had fever on and off, poor feeding, and vomiting. Positive findings when we saw this child, which was about 3 weeks into her admission at Kenyatta, was that she was wasted with a weight for height Z score of less than -3 SD. She was pale, febrile, and she had a large BCG scar that was about 4 centimeters across and large axillary nodes on the left armpit, that the largest was about 3x2, as well as other smaller nodes in the right axilla and inguinal nodes. And then the mentioned joints were all swollen. Her left elbow, they were warm, tender, fluctuant, and they had limited movement, and she also had some swelling on her hand that I'll show you, but no skin or nail changes. The reason I thought this patient was interesting, because you see, she came in with a very rheumatology stroke ID presentation, and we've just been discussing the way the whole team may need to be involved. So this is what the baby looked like. You can see both knees look markedly swollen diffusely. The left elbow, you can see, is fixed in a flexed position. That's the large BCG scar there. And her right hand was swollen with the swelling of the interphalangeal joints as well as the dorsum of the hand. She also had a hepatomegaly. The other findings were unremarkable. So our impression was disseminated BCG disease, systemic juvenile idiopathic arthritis. We also thought of brucellosis and malignancy. And I think even our first speaker pointed out that these children who have PID can present with a myriad of symptoms crossing all the systems. Notable in her labs were a raised white cell count with lymphocytosis and a microcytic hypochromic anemia throughout her weeks of admission, as well as an elevated ESR. The bone marrow was normal, LFTs were elevated, particularly transaminases. We aspirated the joints but didn't isolate any AFBs, and there was no growth. The chest radiograph was normal, and the x-rays of the joints only showed us an effusion. We tried to biopsy the nodes but did not isolate any AFBs, and anti-nuclear antibody was negative, although that it did not still rule out the GIA. So when we saw the child, she'd already completed 14 days of meropenem with vancomycin, but based on her clinical symptoms, we started her on treatment for disseminated basidiosis. I know that diagnosis requires a microbiological confirmation, which we were not able to obtain at the time, but she did start to feed better and there was minimal weight gain. We, however, lost her to follow up after her discharge. The second case is a 2.5-year-old male who was sent to us with a diagnosis of suspected lymphoid malignancy. He'd already been on TB treatment for 3 months before coming to the facility. So he was well 6 months prior before the symptoms developed, treated for recurrent pneumonia as an outpatient, and eventually started on TB treatment based on a chest X-ray, although gene expert was negative. Positive findings: fever, tachypnea, a tachycardia. He had multiple right axillary nodes, small left axillary nodes. And of note, when we saw him again as the ID team, was this diffuse right-sided tender chest swelling. It had fluctuant areas, it was hypopigmented, and it had draining sinuses that were draining pus, but there were no discharging granules. The boy was distressed, he had dullness to percussion, and he had bronchial breath sounds. So it was a very dramatic presentation. You can see this child was so sick, looking with this huge mass over his anterior right chest wall with the discharging sinuses. Again, his labs, very raised white cell count, neutrophilia, high lymphocytes, and HB, I think, had received a transfusion on admission, and after that fell to about 10. So this chest radiograph was the one done in June. And again, Dr. Diana has mentioned the importance of imaging. And you can see that right-sided upper lobe opacity and volume loss. And indeed, anyone looking at this picture would not fault them for starting TB treatment. However, 3 months into his TB treatment, the X-ray looks exactly the same. Most children respond very well to their TB treatment. So if you're monitoring their weight gain, you're monitoring their symptoms. If it's not responding, always ask yourself, what else could be going on? Why is this infection more severe than that the other children have? So he was HIV negative, gene expert negative, pus swabs only grew Staph aureus. We didn't get anything on blood culture. Then we were consulted. You can see I've put up some films of his CT scan. He had consolidative atelectasis, and you can see this mass is actually eroding the ribs and growing right into the anterior chest wall. The pathology team were very supportive, and we got an ultrasound guided FNA, and it showed features of aspergillosis. I don't know whether you can see the arrows showing that those branching hyphae of aspergillus. So voriconazole was not available, and we started the child on amphotericin B, but unfortunately he succumbed on day 3 of treatment. So what's my take-home message from those 2 presentations is that awareness is everything. Yeah, we've said this several times. A very severe infection, is it persistent? Is it unusual? Is it recurring? Is that child keeping on coming again and again? You've sorted out their nutrition and everything else. And I think awareness for everybody in the team, even for me, this whole symposium has really been an amazing eye-opener, and I'm glad that the team have invited me to be part of this. So from the primary care physician to the ID, the pathologists, the support I've received from the team has been amazing. And you can see, because of this presentation, the pulmonologists and rheumatologists were involved in the care of this child as well. And like we've said time and again, good lab support is crucial. So my closing remarks, thank you, Dr. Valerie, is I'd like to acknowledge those patients and their families. Dr. Walong has been a rock through my fellowship. I think he was like my pathologist on call, as well as assistance from my colleagues and Dr. Barasa and Dr. Migoa, who invited me to be part of this team. And last but not least, my mentor, Professor Ndwati. Thank you.
Thank you so much, Dr. Anne-Marie. I am, being flooded with a deluge of messages, some from the pathologists on the investigations from your first case, in terms of the scope, and then others who are giving me a hard time for cutting you off or making you rush through 2 very excellent cases. But hopefully this will provide us with a reason, and we'll petition Dr. Kinuthia to have us all again, or definitely have you and the panelists on to take us through and share your expertise. I'm also a little miffed at you that our disseminated histoplasmosis didn't make it to your case discussion, but maybe for the next time. Thank you so much for your parting shot. I'd like to thank all the panelists, Dr. Diana Marangu, Dr. Lawrence Owino, Dr. Anne-Marie Macharia, and Dr. Eugene Ganga, for taking their time and sharing their knowledge and expertise, and those who've asked questions. and I'm officially calling the multidisciplinary care session to an end. It was excellent, and hopefully we'll have another chance to engage and to share. Moving on to our last but not least session for this afternoon, we're going to have closing remarks from Professor Ruth Nduati, who's a professor of pediatrics at the School of Medicine at the University of Nairobi. She's a pediatrician and epidemiologist who has taught at the University of Nairobi for many years. Her major achievement is her contribution to the understanding of epidemiology and biology of breast milk transmission of HIV, and in the integration of prevention of mother-to-child transmission of HIV in resource-constrained settings. I'd like to also add, though it wasn't put on her history, that part of her major contribution is the number of medical students and specialists who've actually passed through her, that she has mentored and taught. Prof. Nduati maintains an active research collaboration with the Department of Global Health at the University of Washington, and through this has been able to carry out research and mentor several generations of students and researchers who are now leaders in their own right, including the previous panelists, including myself, including the organizers of this symposium. Professor Nduati, it is my honor and privilege to welcome you to give us the closing remarks for this symposium. Thank you.
Good evening. Thank you very much, Valerie. What a lovely introduction. Thank you. Now, since I donated my time to Anne-Marie, I will have very, very brief remarks around this. This has been a phenomenal 3 days where we have reviewed primary immune deficiency. During today's presentation, there was a great summary of how this illness presents, so I will not go into that. What I would like to say is that at any point in time when you identify there's a new health problem or an old problem, and we have relaunched it in terms of the importance, it's important to think about where are the patients and who is taking care of them, and how do we ensure that even with the most limited resources, we are able to optimize care of these individuals. And what I would say, based on our experience with HIV disease, HIV infection, and having worked at a time when we didn't even have resources or drugs, it's very important to distill the key points down, to distill them into guidelines, and to put these guidelines into job aids, and to go out and incorporate them into the treatment and management guidelines that are on the ground. For us, from the Department of Pediatrics, we have a basic pediatric protocol. I would like to urge this team to think about how we could have an additional page that actually addresses itself to this issue of primary immune deficiency, and which emphasizes first careful history taking and flags off what are the important infections to look out for. From the field, you have your 10. You remember your 10 the 10 high risk factors for 10 factors that 10 concepts that should make you think of primary immune deficiency. They're not very complicated, only that people don't know. So if we put them into a guideline, into a job aid, I believe will increase our ability to identify individuals in a timely manner and provide the care that they require. I appreciate the emphasis that was made on malnutrition being the most important, the most common cause of immune deficiency in our population, probably followed by HIV. And want to highlight that in pediatrics, about children who present with severe acute malnutrition in the first 5 months of life, 5-6 months of life, the work done by the teams in Kilifi showed that they have an almost 50% mortality rate. Studies that have evaluated home management of malnutrition, those treatment programs that we have, you find that 1 in every 2 children never recovers. So I believe that there's space for improving our nutrition management, but I think there's space for us to go and try and find out, are we missing primary immune deficiency in these individuals? Now, of course, once we identify individuals, you need to have a plan of how to manage them. I think it's critical to strengthen the medical microbiology lab. There are very few hospitals in Kenya where you can get a decent microbiological diagnosis. Very few that actually do culture work. And I think I throw the challenge to the departments of pathology that we need to look at this. Maybe we need to develop some of these intercalated programs, an undergraduate intercalated program in the area of microbiology, stroke, pathology, so that we increase the number of people who are interested in the microbiology lab, and in that way increase the access to these microbiological services. Now, I've had here the discussion about bone marrow transplant. Bone marrow transplant is a life-saving intervention, not just for primary immune deficiency, but also for patients who are, particularly the leukemias. For as long as I have practiced as a medic, we've always talked about the importance of bone marrow transplant. I think this is a time for us to actually move that way and start very systematically trying to develop those services within Kenya. Now, as I conclude, I want to thank everyone who has been on this panel and to encourage you. Every area of specialty that we have developed has been based on 1 or 2 people training, and those 2 people being so motivated to actually have a specialty service developed. I'd like to give the example of Professor Christine Joey. Before Christine trained, all the pediatric wards were awash with children with chronic heart disease. They were in failure, they were coming in late. It was, sort of like, that dead-end diagnosis. After her training and building skills for us, we now know that these are manageable problems. You can identify them early, you can make a difference. So I want to say thank you very much to this team, encourage you to do what you're doing, and we'll support you as you go forward. And thank you to the KNH team, Dr. Kenothia and your team. This platform is phenomenal. It's given us an opportunity to learn and to share. Dr. Edwin Walong, when I grew up as a medical student, we used to have post-mortem sessions every Tuesday morning. I wonder whether now, when you have many more pathologists, you have Valerie, you have Anne Barasa and others, whether we can't actually revive this, because then this can become the focus of the beauty of these last 2 presentations. Shouldn't just be the one-off. It should become the focus of what we do as on an everyday basis. So thank you very much for inviting me to say the last word. I'm proud of all of you, and I know that the future of medicine is in great hands with all of you there. Thank you very much.
Thank you so much, Dwati, for your service, for your mentorship, for your leadership in both pediatrics and in research and in education. And thank you so much for those closing remarks. I would be remiss if I didn't let, since he's come up on the screen, Dr. Walong say hello. I'll mention I'm very strict with time and we have less than a minute. Do you want to just, and there's a question here I've been accused of ignoring on, apart from gender bias, are there any other risk factors for cancer? I don't know if it was specific to these patients, but I will recommend that the person who's asking the question gets in touch with you or Dr. Barasa. Yes. Do you want to say anything?
Thanks. I hadn't prepared a speech. I just want to thank
Which is good for time.
And of course, my colleagues, we work closely with the pediatric team, and of course, we want to also work closely with the internal medicine team. It's a lot, there's a lot that's required, and a lot of these, we are picking them up from the autopsy room, and now we want to, personally, I want to work hard to reduce my own workload on the autopsy side, and work harder to sustain life on this other side. So thanks, and I'm happy this team is here guiding as we go through this difficult area. Thank you.
Thank you so much, Dr. Walong. I will mention that you seem to have a bias for PIDs. He says more nice things about the Department of Pediatrics than he does about the Department of Human Pathology. But I guess we also need to pull our socks up. I'm just going to hand over very briefly to Dr. Anne Barasa before I wish everyone a good night. Dr. Barasa, as the organizer, please say a few words.
Hi, everyone. My last few words are, I deeply appreciate all the attendees, my co-organizers, presenters, panelists, everyone. Dr. Kinuthia, thank you so much for hosting us. Dr. Kinuthia was surprisingly very excited about this webinar. Prof. Ndwati, what you have, your final comments, we've definitely taken that into consideration. We're going to continue working together as a team. Again, I just want to appreciate Nala, all her comments, all her support, and with that, of course, the African Society for Immunodeficiencies, all my colleagues at KNH, at UON, Aga Khan, Gertrude, the registrars, both at KNH and well, Dr. Mutua was working at Gertrude's before he came back as a registrar. All the moderators, I think you've done a really good job. And I think now that we've really taken long strides in terms of advocacy and creating awareness. One of the other things I want to mention again is the patient society or the patient support group. If you come across these patients, remember, because they're immune deficient, they do need a lot of support in terms of counseling. You need to ensure they are adherent to their treatment. For example, if they're on prophylactic medication, their monthly or every so often clinic visits. So I think the patient support group would be very important to refer, or like an important tool to help these patients and their caregivers as they go along the journey. So please don't forget that aspect. And the other thing we want to do now is also work on increasing capacity for diagnostics locally so that it's affordable for a lot of the patients, especially in the public health setting. Thank you.
Thank you so much, Dr. Barasa. Thank you again to all our panelists for joining. A big thank you to Dr. Kinuthia for seamlessly allowing us to have this platform and for the coordination, to Professor Ndwati, to Dr. Nalo who's joined, Dr. Migoa, who I saw on the panel, and also as contributor presenter on day one. I'd like to thank our almost 500 attendees for taking the time out, Dr. Barasa for inviting us all to participate. And of course, I would like to recognize the patients who actually we're here for and to serve. So a challenge to the A team and to all the panelists here. We look forward to having a PID clinic, at KNH with the University of Nairobi. We look forward to seeing your registry and also having a multidisciplinary team where we can all contribute and learn from. So I'd just like to thank everyone once again and wish everyone a good night. Thank you so much.
Thank you, Valerie.
Yeah, thank you.
Thank you.
Bye-bye.